Good morning, George. It's wonderful to see you. We have two phenomenal guests today on a very important topic to all pediatricians.
Yes, welcome. Today we have Dr. Bai and Nicholas Kleinsworth, and the topic for discussion is One Beautiful Big Bill and a Promise for Our Children. Take it away.
Dr. Bai is a friend of the podcast and a leader in healthcare policy, holding the title professor at two schools in Baltimore, including the prestigious Bloomberg School of Public Health. Mr. Nicholas Kleinworth is a policy analyst at Paragon Health Institute, specializing in Medicaid, a think tank, and more in DC that leads a conversation on how to responsibly finance health so that our children and grandchildren can have a healthy future in a country that can afford its bills. One of the best resources for those interested was the roundtable that Dr. Bai hosted at Hopkins with Senator Cassidy, Dr. McCary, Dr. Atlas, Brian Blaze, and the head of the CBO last year. That's available on X. Because of the complexity of the topic, the show notes will be a little different this time, as I'm going to try to put as many of the references into the show notes. Welcome both. Dr. Bai, Mr. Kleinworth, it's a pleasure to see you. Dr. Bai, would you really share with us all those things that you do at Hopkins and all the writings that you do for journals?
Thank you so much for having us. We appreciate your time and interest, Dr. Bravo and Dr. Lugo. As you mentioned earlier, I'm a professor at Johns Hopkins, and my interest is in the intersection of healthcare finance and healthcare policy. I'm trained as an accountant, so anything about money interests me, especially now in healthcare. It's so complex. People have all sorts of different views, but for me, almost all healthcare policy issues are monetary issues, right? Because about money, and all healthcare actions can be viewed from business perspective, transactional, benefit, cost, incentives. So that's the approach I use, and I found very productive in terms of the ability to interpret, explain, and predict. Thank you so much for having me.
Thank you. Nicholas, what is Paragon Health Institute, and what work are you doing there, and what work does the Institute do?
Thank you, Dr. Bravo and Dr. Rogu, for having me on. The Paragon Health Institute is an independent, nonprofit, and nonpartisan public policy think tank based in Arlington. And our job is to analyze healthcare policy in America and find ways to empower patients and empower free markets in the healthcare policy space. We are funded by small private donors. We don't take any corporate money. And I've been working for the Institute as a contractor for a few years, but I started full-time only recently as their policy data analyst. Started earlier this year doing that, relocated my family out here to the Arlington area. And so a lot of what I do, if I were to summarize what I do, I help people understand complicated data questions on Medicaid and state level policy. I come from a public policy think tank in Idaho. I terribly miss the wonderful frontier out there, but happy to come out here and bring my expertise on state policy and Medicaid.
Wonderful. So I'm in a level set because I think, unfortunately, the white coat organizations, and particularly what I call the public relations for the DNC organization, does not look at data or outcomes. They simply parrot the talking points of the DNC when it comes to policy. So for those of you who are interested because you pay taxes in the U.S., currently, Social Security is $1.8 trillion of a spend, and Medicare is about $800 billion. That is $2.6 trillion, and we collect $1.35 trillion in what people call FICA taxes, or what you pay in Social Security and Medicare wages as you are being employed through your lifetime. So we're already at $1 trillion deficit there. The interest on the debt is between $800 billion and $1 trillion right now. It is a bigger spend than Medicaid and defense as cost. And most of us have mortgages. And when you have a mortgage, you're not allowed to just pay your interest. You have to pay down your principal with the idea that at some point you will close the note out, 15 or 30 years. The U.S. government does not pay any of its debt. it only pays interest on the debt. So the principal continues to be there for our grandchildren to have to pay for it somehow. The remainder of the budget is 2.29 trillion, and there's only about half a trillion left to cover it. So currently we are spending about almost $7 trillion, and we're bringing in $4 trillion. So we have a yearly deficit of $3 trillion that is accumulating to our grandchildren's detriment. In New York, the budgetary outlook is incredibly perilous. Their budget is $270 billion a year. Of that, 120 or so go to education. Another 120 go to financing healthcare. And of that 120, 100 billion go to paying for Medicaid. So Medicaid is 40% of the budget in New York, and they have trillions of dollars in unfunded pension liabilities. So at any given moment, and Governor Hochul has done it, she did it last year, she cut back quality incentive program funding to fund one of her other projects by $250 million. But at any point, if the economy goes bad or enough multimillionaires leave New York City, New York will have to cut back on what they spend on Medicaid. Nothing to do with the public policy at the federal level. They just can't afford to continue to do this as they're doing it. And that is, I think, the reason why people like Paragon Health Institute and the Bloomberg School of Public Health have been advocating for responsible spending and free market solutions to the fiscal crisis that healthcare has become in the United States. George, Medicaid in 2019 spent about $400 billion. In 2024, we had a spend of about $900 billion. What does the data show that we got out of that doubling of spending in kids' health and outcomes?
We noticed that there was an increase in the amount of patient volume or patient rosters on children with Medicaid, meaning that they frequent the doctor's office more frequently. And money-wise, reimbursement is pretty much the same or less for the independent practices. And we're seeing lots of large hospital systems taking over smaller independent practices and engulfing them, simulating.
George, more specifically, what does the published data show? So there is a recent article from JAMA Pediatrics that I put in the show notes for you. In the US, infant mortality is almost twice greater than the OECD 18 countries. That is because Medicaid is a rationing program where they pay less for the care their children receive and less for prenatal care. We know that if you give good prenatal care to mothers, you decrease the amount of prematurity, which is the number one reason why these infants are dying. So we have doubled the spend on Medicaid, put the country in a perilous arena financially, and we're not getting anything from the outcome side. Number two, what has chronic disease gone in children from that same article from the time that ACA and Obamacare expanded Medicaid and today? What percentage of our kids are suffering from chronic illnesses today?
There's an increase. I don't know the percentage, but there's an increase.
It's 45.7%. It's grown from 40% to 45.7%. So the expenditures have been useless because the outcomes have not improved. In addition to that, a very wonderful article published in the New England Journal of Medicine showed the Oregon experiment where they could not add as many people as they wanted to the rolls of Medicaid. So they had a lottery system. So they had a wonderfully randomized trial that was controlled. And they showed that after expanding Medicaid for adults, there was absolutely no change in outcomes. Geez whiz, the article says, but people didn't feel as concerned about being in bankruptcy. Oh, of course, yes, but none of the health outcomes improved. So this spending does not improve outcomes. And at the end of the day, I'm a doctor. So if I'm going to give you amoxicillin, I expect your infection to go away. I just don't give it to you because I can give it to you. And that is a problem. The outcomes do not change with these programs. We just get deeper in the hole and we burden our grandchildren with more debt. Nicholas, so what is the community engagement portion of the One Beautiful Bill? And why is the PRDNC saying that it is going to hurt children and it is going to kick out children out of Medicaid and it is going to affect all pediatricians providing care, whether they're taking care of commercially insured or Medicaid-funded patients?
The community engagement requirements are designed in such a way to where we're trying to make able-bodied, working age adults, so those on Medicaid expansion and only those in expansion states, engage with the community. Because of the community engagement requirements, the idea is that if you can connect people with the community, whether it be through work or volunteerism or other way, like education or workplace development, then you can help them get out of this cycle of poverty and welfare. I think that the claims that children will be harmed by the community engagement requirements are disingenuous. In fact, I actually think the community engagement requirements will only benefit children. We know that as parents do better, children will also do better. As parents lead more independent, constructive lives, the children will also carry on those habits and be able to build on that generational success. And so I think that these community engagement requirements will actually build on themselves and help future generations of Americans, especially as programs like Medicaid also need to see a reduction in the number of people who are on the program relative to those who are working. Let me throw one statistic out here where there's actually more people, double the number of people on Medicaid than there are people in poverty. The program is no longer for the poor. And we need to be able to reverse this trend in order to preserve the program for the truly vulnerable.
So I think that those are all very good points, and thank you for sharing them. But I think that's very important not to demonize the opposition. So the American Academy of Pediatrics, its higher hands and managers are not the American Academy of Pediatrics. The American Academy of Pediatrics are hundreds, if not thousands, of pediatricians that work for free to provide the academy content that then they sell to pediatricians and the government. And those people work very hard and they're very genuine. But the core of the American Academy of Pediatrics management right now is diversity, equity, and inclusion and global health. And within that paradigm, they are supportive of a single payer system. And they have put a policy statement out advocating for all children, including illegals and non-residents, to be covered by Medicaid without any means testing and without any need to re-enroll. And that is, most people are familiar with that policy, but that closely aligns with the bill that the former senior senator from Pennsylvania put in Congress last year. And that is unworkable. So let me tell you an example. So there is rationing in Canada and poverty in Mexico. So you can get a tourist visa across the line from Toronto into Buffalo and get your kid's MRI done. He qualifies for MRI. Why should the taxpayer, the farmer in Iowa or Kansas, be paying for MRIs for children from Canada because the government won't do what's right?
Well, I think that's an illustration of how things like the work requirements and things like providing taxpayer subsidized programs can really negatively impact the healthcare systems. One thing that we saw when states expanded Medicaid is people who were traditionally enrolled. So those are people who are disabled, pregnant women, children. They all had a more difficult time accessing care and coverage. And the problem has only gotten worse over the years, especially as more and more ineligible people are enrolled on the program. The Paragon Health Institute estimates that there are 6.6 million people who are improperly enrolled in Medicaid. So either ineligible for the program entirely, or they're enrolled in the wrong part of the program. So maybe they're enrolled in expansion when they should be enrolled in a different part that would give them the benefits that they actually need. And a combination of these things means that the program's not actually serving the people it was intended to serve originally.
And so I hear this too a lot. The world's going to end because all these able-bodied adults who are not working and receiving benefits are going to be out of an option for healthcare. So they're going to overwhelm our emergency rooms. in New York, because George is from New York, so this is very interested, of a keen interest to him. We already know that 70% of the expansion bucket, which is about 2 million people in New York, are working. They meet the requirement. So the at-risk people that will have to fill a piece of paper is 30% of the working able. Children are not going to be required to send in a paper saying that they're working. Parents of children on Medicaid are not going to be asked to send a paper that says that they're working or in school 20 hours a week. In fact, they're exempted. So it is disingenuous, as you say. I would say it's more near to lie to scare pediatricians into selling into health systems and private equity or retire early because their population is going to decrease and they're not going to make money. That is not seen in the data. And we should be looking at the data. We're scientists. Physicians are scientists. So we should look at the data and help our colleagues and our policymakers make smart decisions based on what we know as the data. The other one that irks me a little bit, what is this about everybody's going to have to pay $35 when they come to see the doctor?
So I would say that's actually an extension of the work requirements in the idea that we're preserving the program for the truly vulnerable, and having people, giving people a stake in their healthcare coverage. Keep in mind that the copay requirement, the $35 copay, is actually already in the Medicaid program. Haven't done a very good job enforcing the copay. Isn't the One Big Beautiful Bill increase the requirements to enforce the $35 copay? And keep in mind that this only applies to expansion adults above the poverty line. So people who are below 100% federal poverty level won't have to pay the copay. But those on Medicaid expansion, the able-bodied working age adults, will have to pay that $35 copay. And I think the concept of the copay is actually quite simple. If you were to go to Costco, for instance, you notice that everybody is gathering around at those free sample stands, and everybody is getting it. Not necessarily because I hope we don't have a food epidemic in Costco where everybody's starving while they're shopping and they need food. But what you find is that it's a free sample. So everybody's going to access that service just because it's free. But then look at how many people who took the sample actually go and take the next step and buy the product off the shelf. Very few people actually go through with that next step where they have to make that analysis of whether or not the cost of going and purchasing that product is worth having the product. And I think similarly for healthcare, people will respond to incentives. If you have to pay a $35 copay, you're reducing frivolous admissions to things like emergency rooms. People aren't probably going to go to the emergency room for a cold, but if you have to pay a $35 copay, then they'll have to consider whether or not the product they're receiving, which is services at the emergency room or at their physician's office, will actually be worth what they're getting back. And this does a few things. This helps preserve things like emergency rooms, emergency care, and healthcare provisions for people who actually need it. It prevents the frivolous use of services, and it preserves the program for the truly needy.
And will this apply to children, and will this apply to people in primary care? Will this apply to women seeking prenatal care? Will this apply to people that need mental health services?
So a lot of these populations that you mentioned are actually traditional Medicaid enrollees. They're not enrolled through Medicaid expansion. So when a woman, let's say she's not pregnant, she enrolls in Medicaid through Medicaid expansion, and then she gets pregnant, the state is supposed to move her from the expansion category to one of the traditional eligibility groups. And at that point, she is no longer required to pay the copay. Before she was pregnant, she would have had to pay the copay as an able-bodied working age adult above the poverty line. But now that she's pregnant, she falls in a different category group and she should be paying the copay. Like children, likewise, are not subject to the $35 copay requirement. And I think the way that it impacts children is that it will leave these services available for children. So you go to the emergency room, you won't have people stacking up in the emergency room for care that may or may not need.
Yeah, I don't think the bill went far enough. I think the copay should be required for children outside of the primary care or their medical home. That would cut down significantly in the low value of care that is received at urgent cares, that is often unnecessary and should be given at the medical home. It would also strengthen the medical home by providing them with more revenue. So I think it didn't go far enough. But I'll give you a clinical example. About 2 weeks ago, I saw a family, Middle Eastern, I think they were immigrants. The child was 18. He was on holiday at the beach and sprained his ankle, and I saw him on Thursday. There is a very nicely published study from Ottawa that says if you sprain your ankle, but you can bear weight on it, it's not fractured, you don't need to x-ray it. Put her in a boot, send them to physical therapy, wait 2 weeks to see how they're doing. If they're not improving, then x-ray it and refer to orthopedics. That's excellent care. It doesn't cost a lot of money. The boot costs $35 on Amazon, and they deliver it the same day to you. And to me, if you're already getting the care for free, you should be able to spend $35 on your child. The father would not leave the office until I gave him a referral to an orthopedic surgeon because he wants an MRI of the ankle, because he's on Medicaid and it doesn't cost him anything. And that's the problem. If the consult with the orthopedics would cost him $35 and then the MRI would cost him $35, he wouldn't be asking for it. He'd be happy to get the free physical therapy, buy the boot, and see if in 2 weeks we really need to do anything else. That's behavioral economics, and it's very important that we are kind to people that need. That's our Judeo-Christian society and ethos. But we also have to ask people to be somewhat accountable and responsible. It's kindness in return. If we're giving you things for free, we need you to be kind and help us so that we can keep providing for those that need the most. This is not about hating the poor. This is not about hating children. This is about the honest truth. There's limited resources on earth. There's limited water, there's limited land, there's limited dollars, there's limited gold, there's limited men, there's limited gold, women. So we must be good stewards of our environment, our societies, our people, and our wallets. I don't understand why they find it so hard to understand.
If I may add,
Sure.
Dr. Bravo, it's such a great point. No matter what people's beliefs are, we have to accept people do not care as much when they spend other people's money. And that's true when it comes to you give your children allowance versus they earn their allowance, earn their own money. And in this case, Medicaid, they follow exactly the same underlying truth, as you said. People don't care when they spend other people's money. So we want to be, helping. We really want to lift people up, but we also have to recognize the need for trust and verify, right? So I think this is at the key of this Medicaid debate.
Yes. And recently, the Wall Street Journal, was to the point that you guys have made before, published a paper on what Dr. Oz did at HHS. So Dr. Oz found that there was 1.2 million children enrolled in 2 states and 1.6 million adults enrolled in both Medicaid and subsidized ADA. And that total about 14 billions in fraud. Where does that money go? When I pay a premium and I don't use anything, who benefits? Dr. B?
Yes, that is actually committing, please forgive my language, that's committing fiscal crime against taxpayers. If you are being too loose and not being as strict as you should when it comes to verifying the Medicaid program recipient, then you are actually committing fiscal crime against taxpayers. It's no free lunch, right? You cannot be, okay, I'm being responsible, accountable to taxpayers, but at the same time, I'm giving everybody who wants free care a benefit. That's just not going to happen. And also, I actually heard from my colleagues that sometimes people use too much medical care to the detriment of themselves. For example, it does not cost money to do a CT scan. I will do many CT scans. Guess what? The exposure to the radiology actually hurt them in the long run. So in many cases, the cheaper care, as Dr. Bravo said, that's a routine care to help patients more than the more expensive care. So I think, unfortunately, at the end of the day, many of those well-intentioned measures cause patients suffer more.
So, Nicholas, so that 1.2 million times 3,000, it's about 7 billion, I think. So if I'm paying for a premium in Virginia and a premium in Maryland, and I don't use my Maryland premiums for anything, isn't the CEO of Centene and the CEO of Elevance and the CEO of United Healthcare putting that into his pocket for his private plane? Because society is not deriving any benefit from those payments, are they?
That's exactly right. When states are paying premiums for people who aren't actually using their services or people who aren't actually supposed to be on the program to begin with, the people that benefit are actually the insurance companies who are running the Medicaid programs. Currently, there are 40 states who have what's called a managed care arrangement, where the state hired an insurance company to run their Medicaid program for them. The other 10 states run those in-house, and so they don't have to pay that monthly premium for the Medicaid enrollee. But those 40 states are losing out on money if there are people who are enrolled in multiple states. And those managed care companies, the problem is they're supposed to, in part, verify eligibility. They're supposed to help make sure that the rolls are clean. We saw that over the COVID pandemic, a lot of states, they weren't allowed to remove the people who were ineligible for the program unless they moved out of state, asked to be enrolled, or died. And what we're finding is a lot of those people were never actually removed from the rolls. And so the insurance companies have continued to collect those premiums from states for people that were never going to receive services because they didn't live in the state. And it's a huge injustice to the taxpayer, because if you were paying for a service that you weren't going to be using, you would probably turn off the service. And the government paying thousands of dollars for these people in the program should be no different.
Yeah, I see that a lot when we have the quality incentive programs, where we're trying to do the right thing and get the patients to come in for their well care and their vaccination. And my nurse is called to make an appointment. Oh, they're out of state. So they're living in another state. They can't come to us, but they keep the New York State Medicaid because they do come every 6 or 8 months to stay with grandma. So they want to keep both plans. Now, we've alerted a lot of these managed care plans to this. They couldn't care less. They said, we cannot remove them unless they do it themselves or they die.
Or the state takes them off the rolls.
They won't take them off the rolls.
So this is chronic capitalism. And I'm sorry, this is very political. This is the Biden White House. They're funneling money from the taxpayer to the to the claims managers, United Healthcare Community Plan, who then funnels the money to the hospitals, which is their big constituency for the Biden White House. Just like they did funnel money to Pfizer for routine boosters in children of COVID, which 90% of the US says, no, thank you. That is poor governance and it's dishonest. So to the point of what is the burden going to be? So now they're going to ask, and I don't think it's implemented for a couple of years, anyone that enrolls in Medicaid, they must have a state address that can be verified. Correct, Nicholas?
That is correct. So when people are enrolled in Medicaid, they're supposed to have a state address and they have to pick one state. And there is going to be a federal database that the states will have to check against to make sure that people aren't already enrolled in another state. And keep in mind, this database is also doing other basic things, like making sure that the people aren't dead, but also enrolled in Medicaid. That's another chronic issue that's costing taxpayers a lot of money, but the insurance companies are making a big amount off of. And keep in mind, just to put this into perspective, Paragon actually just recently did a joint study with with an organization called Epic. And they found that if we were to check for eligibility, keep in mind the Center for Medicare and Medicaid Services, they actually haven't been checking for eligibility the last few years either when they're determining whether or not payments were improper in Medicaid programs. But if we were to check for eligibility as they should have been all this time, over the last 10 years, the federal government has wasted $1.1 trillion on people who should have never been on the program to begin with. And that's not even talking about the people who are duplicates on the Medicaid rolls.
And then there's another requirement, I think it kicks in 3 years. People are going to have to provide their Social Security number in order to be enrolled in Medicaid, correct?
I don't know about that detail, but it would make sense to have to provide a Social Security number or some form of identification to be able to enroll in public benefits.
And the reason why is what I said earlier, right? We don't want tourists coming in here and getting free care at the expense of the taxpayer in Kansas, the farmer in Kansas or in Iowa. So it's not about phobic on immigration, or I hate people of color, or I hate people from other countries. I wasn't born in this country. I was born in Colombia. And I have cousins in Colombia still, but I don't think that I should be able to fill a prescription for my cousin in Colombia and mail it to them and have the U.S. taxpayer pay for it. That's just not right. They haven't contributed. Even Medicare acknowledges that. You are not eligible for Medicare if you haven't worked for 10 years and contributed. You have to pay a premium on Medicare. So this is a long-standing tradition in the U.S. from the very liberal side of the Democratic Party. It was Johnson who instituted those laws in Medicare in the 1960s. This is not, I'm not crazy. This is how they designed the Medicare program. You contribute for 10 years and then we'll take care of you. Not show up at the door and we give you freebies. That's a fundamental difference. And I think the other one that's gotten a lot of pediatricians on the nerve is that there's going to be verification every 6 months. My understanding that is for the able-bodied adults, because many of them qualify at an income near the poverty level, and then 6 months later they're working and they're making too much money and they could buy insurance in the exchange. And I'll get to Dr. T about how important that is in a minute. But is that my understanding correct, Nicholas?
Yes, that's exactly correct. You want to verify multiple times a year. And keep in mind that the Biden administration, they instituted these enrollment at any cost policies that force states to only verify enrollment only once per year. And of course, your income is going to change. Your circumstances are going to change. Especially if you qualified for something like income. Now, it doesn't make sense to apply this kind of a policy to people who are disabled or even people who are pregnant, because their circumstances pretty much only change once a year. And you should just verify that what their eligibility based on those categories. But for people who are enrolled through Medicaid expansion, this makes sense. And this policy really is limited to just the able-bodied working age adults who are on a Medicaid expansion program.
Yeah, I think what the fear is with all the verifications is what happened. I think the states have too much power where they now go back in time and they re-verify and they find out and they do clawbacks to their doctor's office, and their doctors are, helpless. Example, I have one managed care Medicaid plan that had Child Health Plus. Patient had Child Health Plus for years, forever. 23 years old, came to our office during COVID, during that time, like it's about 4 years worth of visits. Had autism. All right. So what happens when you have autism? You're eligible for Medicare. Nobody knew. We're pediatricians. We don't have Medicare. So now these guys are going back, pulling back 3 years of visits because Medicare has to go first. The insurance company should not have that power.
That happened in commercial insurance too. I had more than one time when I ran the urgent care where Aetna would pay, and then 6 months later they would do an audit, and I get a list of 10 people that didn't pay their premiums, and they would just claw it back. You're helpless. You can't do anything. They just claw it back from forward payments, and you're not going to go sue them because they got in-house lawyers that will beat you. So that can't be fixed. Let's talk a little bit about New York Medicaid, because it's quite an irresponsibly run program. In New York, you can qualify for Medicaid for children at 400% of poverty line, which is a way outlier from every other state, and they pay between 85 to 90% of Medicare rates. 400% of poverty line in New York is $120,000. For people in Idaho, Kansas, Iowa, Missouri, $120,000 is hitting the jackpot. So that's a problem. And my friends and my colleagues and people that are in these white coat organizations are screaming and setting their hairs on fire because of the OBBB. And then they go burn a Tesla. But in 2019, the state of New York was paying around $4,481 for care to children provided on Medicaid. By 2021, they dropped it down to $2,863, a 30% haircut for children, while they maintain the same amount of payment on the 2 million able-bodied enrolled. Where are the white coats screaming about the crime against children in New York? Where are they? Please comment, write to me. Tell me that you think this is fair. Tell me that you think this is how a program that should benefit children who can't provide by themselves, and you give them a 30% cut is okay, because it's not. And then let's talk about something that's very interesting, which is the fleecing of the American taxpayer. So the reason New York has 2 million able-bodied adults on the Medicaid rolls is because they don't pay for it. They don't contribute to it. So it is unconstitutional. This government is by the people, for the people. And we are supposed to have no taxation without representation. So what's happening is Hochul in New York, it's taxing the U.S. federal taxpayer to expand their spend in New York. And it is a tax, but I can't vote in New York, so I can't vote her out. That's unconstitutional.
If
And
I
that's
may add here,
yeah.
Dr.
Yeah.
Robert, this is great. I just want to briefly summarize what happened like in New York. There are two layers of spending other people's money issue. The first layer is just, you mentioned earlier, patients not paying money out of their pocket, so they cannot overuse. The second layer is very similar to the first one, that is the states are using federal money. So the more they expand their Medicaid pie, the more money they get from the federal government. So that is a fundamental incentive, wrong incentive, to encourage states to spend more. If they can, they probably spend to 600%. If, let's say, we completely detach federal money from the state, probably will behave more responsible, right? Because every money coming from their pocket. Then if we give patients more control of their money, then patients probably will be more responsible. So I think it's for the same line of spending other people's money. Thank you.
So they spend other people's money and the state gets all this money, insurance. Where does all this money go to? Because I promise you, it's not.
We're going to get there. We're going to get there, George, because Dr. Bay has written several wonderful articles on this, and Paragon Health has done a wonderful job. And this is not a partisan issue, even though I might be sounding very partisan today. But the Obama administration, the Biden administration, the Trump administration, the previous and this one, have pointed out something called provider taxes as a problem. And in fact, they had to put into the law a safe harbor to where you were allowed to charge only 6% of revenue from a provider in order to use that money to get more money from the federal government Medicaid. And this money then gets recycled and is given to the constituency. Who is the constituency? The constituency is the big health systems who hire lots of nurses, who are unionized, who vote Democrat. Okay? And so this money is not going to pediatricians, internal medicine doctors, endocrinologists, nutritionists. This is going to the health systems in the form of state-directed payments. And Dr. Ai, how has this been done in North Carolina?
Great, thank you. The provider tax is a scheme. It's quite complicated. I will try my best to simplify it. So once the state want to expand Medicaid, the state has to spend the money, right? So the money comes big portion from the federal government, but the state has to contribute some part of it and have a bigger matching. Where can state find the money? Guess what? They will first tax the hospitals and some other organizations, the many hospitals. So they get the tax from hospitals, it's called provider tax. They get the money from the hospital and then get the matching fund and then pay back more than what they get from hospitals. So it's a win-win for both the state and the hospital, right? Because hospital give the state some $1 and get, let's just make it up, maybe get $2, $3 back. And the state don't even spend any money. I just got the money from the hospital and then got the money from the federal. And then I give that back and I leave something for myself, some leftover for myself. And I can direct. I have my own pleasure as long as about Medicaid. So that's why the incentive is so strong. It will be a no-brainer for states not to take this offer. It will be no-brainer for any hospital to say no. So that's where we end up. We have this provider tax bigger and bigger. And the federal taxpayers are putting in more and more money. And guess what? Let's look at the quality of care, access of care, probably not improvement too much.
And specifically in North Carolina, Novant Health System, which is a mega system, and they would not allow expansion of Medicaid unless they were paid commercial rates for the adults in the hospital. So you're having an able-bodied adult going to the hospital and the Medicaid's paying 200% of Medicare on the ER, on the MRI, on the CT scan, while the pediatrician is at 50 and 75% of Medicare for that visit. What does that do to the marketplace?
Yeah, so great point. On the surface, it is a scam against the federal taxpayers. But once the program starts running, it's a scam against commercial payers in North Carolina. Because now hospitals have a great incentive to increase their commercial price. Because not only they get dollar for dollar from commercial payers, but they also get a higher payment from the Medicaid program, right? That's why in North Carolina, commercial price being higher and higher. And then it's the money coming from employers, the American workers, especially North Carolina, and then federal taxpayers. But I want to quickly make a point that we should not just say, oh, this is just greed from hospitals. I would blame federal government more than the hospital. Because hospitals are working in their incentive structure. They're going to do whatever is good for them, right? So the CEO actually probably be blamed if the CEO does not take up the deal. But the federal government is making it almost impossible to say no to the offer. The offer is too attractive. So I think we have to ask, why did the federal government so eager to make state hooked up to this thing? Probably raising constituencies to push for political agenda. People have different views, but I think the fundamental problem is the policy failure. Thank you.
So I'm going to even push, I'm more aggressive than this bill is, and that what you and Paragon are, okay? This is how communism works, and you come from a communist country. They take 50%. 50% of the people who can't afford to buy bread or get health insurance, whatever, and they start giving them free stuff until they get them addicted to the free stuff. And then they eventually take over the means of production because both the marketplace and the person that's buying are totally dependent on the money that's coming from the government. And then they say, yep, you got a card, you're supposed to get bread, but there's not enough bread to stand in line until you get bread. I'll give you an example of one of our colleagues. He is the endowed chair of pediatrics at Mass General, Brigham Young. They bring in $2 billion in revenue a year. And he's one of the biggest proponents for Medicaid for all children in the country. His CEO makes $5 million a year while losing money. And the average employee in healthcare makes $60,000. So through the lifetime of an average employee, they won't make what the CEO makes in a year. But this benefits his hospital because as long as this scheme is in place, they're going to be able to capture higher revenues for the Medicaid patients, and that funds his endowment chair. And so when he writes policy statements, he doesn't disclose this in his policy statement as a conflict of interest. He just talks about how Medicaid is the engine of America. And it is not. It is a problem. The other problem with the North Carolina, which you have pointed out several times, is that it is destroying the marketplace and independent practices. Because if you want to be reimbursed at a proper amount from health plans and Medicaid, you have to become part of Novant Pediatrics. Otherwise, you will be reimbursed at 50, 75% of Medicaid, and you will be run out of business. Is that correct?
I
Yes,
think
it is
I-
reality.
Yes,
Uh,
I agree.
Nicholas?
I think that's correct. And actually, I reference a lot of Dr. Bai's work on this particular point. And in fact, these payment schemes are so bad that even the North Carolina State Treasurer, Dale Fowle, wrote a letter to CMS pleading them to not approve North Carolina state directed payment program that was supposed to pay down things like bad debt and charity care. Keep in mind that charity care is something that hospitals are supposed to provide as part of their nonprofit status. So they're going to not have to provide any charity care, not pay any property taxes, and they get the revenue from other provider taxes as well. And what does this do? It makes healthcare more expensive for everybody because now we've not only centralized the system, so there are fewer choices for people, not just in rural areas, but also in the large urban areas. So then you have the monopoly problem. But then you also have this issue where if you are setting things to average commercial rates instead of to Medicare, you've incentivized them to continue to raise the average in order to get more out of financing schemes. And by the way, you don't actually have to set them to average commercial rates for these hospitals to be able to game the system and get more out of the financing schemes, because the tax is on a percentage of their net patient revenues. They just need to raise the revenues and get more free money from the federal government. And I want to just clarify one point too, that safe harbor threshold that the Senate added to the bill to lower over the next 5 years. The safe harbor threshold is really, it's not a limit on provider taxes. States can charge as much as they want just for a provider tax, regardless of the safe harbor threshold. What the safe harbor threshold is a limit on the money laundering scheme. So you can charge up to a 6% tax currently and be able to guarantee to that provider that they'll get all their money back. And so if they want to charge more and states are crying that they can't fund their Medicaid program, then they're going to have to not hold providers harmless. And that taxpayers actually, the average taxpayer and the average patient should be excited about that, because now we're actually limiting the cost to the program through that means. So states, of course, are not going to charge a very high tax when all of the stakeholders, the providers, are going to be affected with no guarantee that they're going to get their money back, that providers aren't going to want it to be very high. I think that particular provision in the One Big Beautiful Bill is actually a very helpful provision to lowering the debt. It's supposed to save about $200 billion over the next 10 years.
And to make sure that people are not scared, it is measured. It doesn't start till 2028. And then they're going to cut that safe harbor by 0.5% down to 3% incrementally year by year. So this is not going to be a change that happens tomorrow. If it does happen, because politics is politics and elections have consequences, it will start in 2028. So there is no reason to panic, sell your private practice, quit your private practice. This isn't going to affect you. Please do not listen to the talking points. You're doing good work as pediatricians and independent practices, and you do much better care than the health systems and the private equity. Do not walk away. You don't need to be scared. So I'm going to go very fast because some of you guys are limited on time, but I'm going to hit SNAP. SNAP was asked that there is a work requirement, and I think it's okay to reform SNAP and WIC. We should not be paying $7 billion a year for infant formula when we know breastfeeding is much better. And then the U.S. government gets almost a $2 billion kickback from Mead Johnson and Nestle for selling formula, and 85% of the revenue comes from the federal government. Number two, SNAP should not be paying $10 billion a year to Coca-Cola and Pepsi for people to buy sugary drinks that are addictive and lead to mental illness, obesity, diabetes, all costs that we will have to pick up on the other end, either on Medicaid enrollees or Medicare enrollees, or when you're funding your employee insurance plan. There should not be any screaming. It should just be pretty simple. Coke and Pepsi don't need $10 billion from the US taxpayer to make kids sick. They don't. They can advertise, they can make kids sick, and people can pay out of their own pocket, just like they buy cigarettes, alcohol, whatever else you want to buy, that we don't need to fund it. The OBB also has some wonderful things in it. They expanded the child tax credit. And Dr. Bay will attest to this. If you want to lift children out of poverty, that direct cash transfer is the most efficient way to do that. And so that was a huge win for kids, and they made it permanent. And that is a huge thing. They added a trust account for every child born in the US. Now they get $1,000 from the federal government. It should have been $5,000 or $10,000. We should have been more generous. They expanded school choice scholarships. They allowed for more daycare subsidies through small employers. And the key, the one that I think is what I'm most excited about, which I want to really dig deep with you two about, is they now allow HSA account holders to pay for their direct primary care through that in a pre-tax environment. And that, I think, is the future of the U.S. primary care force. What are your thoughts, Nicholas? Because I'm going too fast.
I think that is an excellent development and does just what Paragon wants to do, which is empowering patients to make the decisions. If the dollar is in the patient's hand instead of in the hand of the insurer or in the hand of the government, and when they're making the decision about what's best for their health, then they're going to make a better decision. They're going to make a decision that's not only more economical, but they're going to make a decision that balances the resources to their needs. And I think that opening health savings accounts to direct primary care is the way to go. And keep in mind, direct primary care was once the way we did things before insurance. If you go back through the history, before we had Blue Cross and Blue Shield and all of these large insurance corporations, the model was direct primary care. That was the model that the market created. And the insurance system was not what free market would have come up with. And so I'm excited to see that we're moving in that direction, and we're moving in a direction that starts abandoning this pseudo market that was never really intended to be the way we administer healthcare.
Maybe I'm wrong, but I don't believe in the Medicaid lines of business there is such a thing as direct primary care. Is there?
Yes, there is. Yes, there is. There is. Drew Hertz of the SES Network in Ohio, and Lee Gross, who's a friend of the podcast and a phenomenal leader in the space, have contracts with Medicaid in their states, as well with, they've done some beautiful things. So Lee Gross has done some beautiful things where employers are moving patients from facilities in a bigger city into the smaller hospital because they have a set price and doesn't go through insurance. And so it saves the employers tremendous amount of money on elective surgeries like knee replacements, hip replacements, things like that. But we're going to talk a little bit about something else. I could talk to these two people for another 3 hours, but do a Rogan episode. But I want to talk to Dr. Bay because she's written quite a bit enumerating how insurance is for catastrophic coverage, not for day-to-day cost, and how we could use the direct primary care model to pay for medical care in Medicare, Medicaid, and commercial. What are your thoughts on that, Dr. Bay?
Thank you. The affordability and access won't be possible until we have competition innovation, right? So these two things, competition innovation, won't happen unless the consumer actually control their money. Imagine a communist party, communist country. I go to the grocery store to buy things, but I'm using some kind of allowed permit from government, and the government pays for it, and I pay huge tax. In that kind of situation, there's no innovation. That's why there's only one type of bread, right? One type of jam. So if we want the innovation, if we want to reduce price, then the only way is to let people control their own money. Guess what? Once people do that, they will be able to benefit directly and personally from better care and a lower price. That will ignite a innovative storm across the market.
And so I have pushed back against your writings because here's where I don't think you go far enough. Okay. So I'm totally with you. And I think my good friend Sue Cressley at the AP agrees with me. Insurance is meant for catastrophic care, not for small episodic care. And in children, luckily, catastrophic care does not happen very often. How we fund that insurance is going to be a little difficult because obviously if you're a father who's responsible and is paying their bills, you're going to pay for insurance for your son. The next bucket, but if you're truly born into an indigent family by no fault of your own, our Judeo-Christian society says we must take care of those who can't. So it will have to be a combination of the state and the federal government who pays the premium for that commercial insurance for catastrophic care.
Actually, we believe that not only we should subsidize patients through HIC, but also subsidize something called reinsurance program, so that when they buy insurance, if they have high risk, without subsidy, their premium will be very expensive. They won't be able to afford it. But it's government taxpayers' job to help fund the reinsurance program to stabilize premium for everybody. And then people naturally with high risk naturally got to combine together. And that is much better, more efficient way than for federal government to subsidize everybody through this expanded insurance apparatus.
And something neither one of you has brought up is that when New York puts 400% of poverty line children into their Medicaid program, you increase the cost of insuring commercially every person in New York. Because the way insurance works is if you get a lot of healthy people paying premiums, that decreases the premiums for everybody. If you take the healthiest population out and you only leave the ones that need the most services, the premiums become incredibly expensive. So that one single policy that New York is enacted is why George's company has to pay $30,000 to $40,000 a year to Aetna for health insurance. Number two, through the HSA,
per month.
I know it's $3,000 to $4,000 a month, but it's 40.
It's 30 per year, per month. All right, go ahead.
Okay. And then where the episodic care, that subscription model at the DPC is the best because then people have no friction. And they have shown that if you have no copay, no cost sharing at your primary care office, utilization doesn't go up, but outcomes do improve. And for those who can't afford it, the government is going to have to fund that HSA in order to be equitable. And I think we're all okay with that, as long as you're at 150% or 200% of poverty line and you're a child, not 400%. Where I don't think Paragon or Hopkins has gone far enough is we need to decouple what is public health from healthcare. And pediatricians do a lot of public health. So we make sure that your weight is normal. We make sure that you're not autistic. We make sure that you're not depressed. We make sure that you don't have anxiety. We make sure that you have your routine vaccinations so that you don't get sick and you don't give measles to the whole school. And so I think that should be something that's funded by the federal government through a public health program that covers all vaccines and gives each person, like they do with SNAP, a $300 amount on their debit card so they can get a physical at a pediatrician if they're under 25. What are your thoughts, Dr. Pei?
I think we should be cautious whenever it comes to a bright line rule mandate from the government. For example, what kind of money is sufficient, right? What kind of things we should mandate to the kids. Because that will open another can of worms, creating unintended consequences. But for me, I think it's more, let's just let the people control more money and then put the physician and the patient together as close as possible. That would be the direction for me.
Okay. Nick, what are your thoughts about a program that would look more like a free market with some government subsidies, because some people will need them?
I think that I fall in line with what Dr. Bai just said, where a free market is good. People need to be able to control their money, but I would be more cautious about what we end up subsidizing, because the government deciding which vaccines get funded or how all that gets decided can lead to some dangerous decisions about patient care. So who gets what kind of care and how, and that doesn't look very free market. I think we end up trending back to where we are. A lot of this started with the government subsidizing things that perhaps the government wasn't supposed to subsidize. I think that if we start with doing things like making the Medicaid program for the truly vulnerable again, instead of putting so much emphasis on able-bodied working age adults. So that means that children are prioritized again, just as we were doing in the One Big Beautiful Bill. And keep in mind, that's just the first step. I don't think that the One Big Beautiful Bill solves all the problems. For example, the one thing that you pointed out with New York earlier, where we reimburse 7 times more federal funding for able-bodied working age adults than for children. Naturally, that's going to create incentives for states to prioritize the able-bodied population over the traditional populations. So those are things that we need to make sure eventually get addressed. And I hope that we trend in that direction. And I'm excited about this first step.
And if I may add, imagine every New York kid, baby, got a subsidized amount in their debit card. And if you are low income, you have more. And then let pediatricians do what they do best. Find the best way to appease patients, to gain business. I think that will be much better than government saying, oh, you guys have to do whatever. Because that's really the root of what true innovation and affordability access.
Thank you.
I think we need to come back together to devise the new plan. My friend Peter, not Peter and Jesse, they call it Shirley, not Medicaid. But thank you so much for your thoughts and the work that you're doing. I follow you both and both of your organizations closely. And I just love what you do. And I think that you're absolutely right. A free marketplace where independent practices who are accountable to the person in front of them is how you change the outcomes in America, how we make our children healthy again, and we innovate, and hopefully we can leave our grandchildren a government that can actually pay their bills and not in bankruptcy. So thank you very much to all of you.
Thank you.